Well, good morning, everybody. For those of you like me who can't be in the two places at the same time, this is the day and time of the BMT CTN fall meeting. So thank you all for coming today. We have a full agenda and a new trial concept. So let's just get into it. Amrita is in clinic and has agreed to give us an update of SWOG 1803, the multiple myeloma maintenance trial. Amrita?
Oh, no, I was trying to hear you, actually. I couldn't hear you. Now I can. So, thank you, everyone. I'm going to present the dramatic study, again, S1803 BMT 1706 on behalf of myself and Sarah Chabra, who's the CTN co-chair. I'll quickly go through this just to remind you that this trial is a large trial randomized either after autologous transplant to len or Lendera. And then the most important point is the second randomization at 2 years, when patients are randomized based on MRD status to either continuing maintenance on whatever their assigned arm is or stopping maintenance. And this is important time because now we have a fair number of patients who've reached that time point, and we've actually learned quite a few things. And as you'll see, this has led to a substantive protocol amendment. Next slide. Again, reminding you, why is this such a large study? Because it is powered for overall survival, and overall survival in myeloma is now very long. Secondary objectives, and this will be one of the readouts earlier, is MRD negative rate between the treatment arms. And another important thing, and I do want to thank the Quality of Life Committee from SWOG about this, is Natalie Callender is leading our PRO QOL as well, because this is a really important thing when we're talking about maintenance therapy. Next slide. So, this trial was a long in conception, starting way before my time, actually, 2017. Ultimately, many iterations. We opened and enrolled in 2019. Very exciting that our Canadian colleagues also joined in 2022. And again, thanks to all SWOG operations, that was a huge effort in regards to many things in terms of drug delivery to make that happen. We added another important quality of life amendment, the null antigen actually mandate, and the key one on revision 6, which I'll get to, was mandating that patients have a baseline sample so that we could do MRD. And I'll speak to that when we look at the MRD. Here is our biggest challenge. So we met our initial accrual goal and then temporarily closed to accrual, as you can see here, when we got to the 1,100 patients that we needed. But we ended up with a second amendment because now, as patients reach that second randomization time point for MRD, it became increasingly clear that our initial patient group, the MRD failure rate was high, over 20%. Maybe we can go to the next slide. So, I guess the good news is obviously our accrual is extremely good. Next slide. And again, continuing to be until we had to temporarily halt accrual, also extremely good. And these are the sites enrolling, and thank you to everyone participating and their robust participation in this trial. Next slide. Here is the issue now that I wanted to speak to. So the issue was our failure rate was over 20% initially. We made substantive efforts to bring that down. One was that initial amendment I showed you, requiring that we had a baseline specimen, so that helped. The second thing, myself and Dr. Chabra went back to sites that didn't submit baseline specimens for patients and called the PIs. And again, thank you to all of you, to ask you to go back and help try and track down those specimens. And we were able to, again, get some additional patient baseline samples from that. And now our MRD failure rate has gone down to less than 20%, which is encouraging. Some of these things we have no control over in terms of polyclonal samples, or if the baseline specimen failed, and just in terms of quality. But again, because of this, we really needed to make sure we had enough patients to meet that MRD randomization statistically. So we had to increase accrual by about 300 patients. Next slide. So here you can see we revised it from 1100 to 1420 to account for this. We also clarified the definition. This is getting the weeds just based on, again, review. And now myself and Dr. Traub are actually personally, both of us adjudicate each MRD analysis. Next slide. Cytogenetics, this is the biggest question that's also come out, is there a bias? Are patients not enrolling high-risk cytogenetics on this? What is going to be the outcome of the high-risk cytogenetic patients? So we have here a subgroup now of study champions who are looking at patient-level data and FISH reports, and we will be collecting that data. Next slide. We made a few other things. Some of the things that we realized, some sites, very few, fortunately, it's been about 2 or 3, reported their MRD using flow. We could not use flow. It has to be the centralized through adaptive clonoSEQ assay. The other thing is mandated that many sites, again, understandably, patients don't like to do it, but the UPEP was not being done at the 24-month, and we do need that as well if we want to call complete remission, because we didn't want to underrepresent our CR rates, which happens in many large myeloma studies. So again, now we've made the UPEP mandatory, and we don't release the MRD unless we have the UPEP. This is our biggest challenge in terms of enrollment. So Revision 8 has been approved by the NCI. It was actually approved in August. We are still awaiting contracting between SWOG and Janssen, and that is really our holdup in regards to being able to reopen accrual. These are the interim analysis. These are actually going to be pushed out because the number of deaths is actually lower than this, which is, a good thing. Next slide. And again, I'd like to acknowledge everyone and thank all the sites and for their robust participation. And, our biggest challenge really is being able to reopen. If we are able to reopen and stay on our current accrual goal, it will be 1 more year and we'll be done. So literally every week we are in contact with SWOG operations with our fingers crossed about if the contract can be executed. Thank you. And I'm happy to answer any questions.
So any questions for Amrita, please? Okay. Thank you, Amrita. Enjoy clinic.
Thank you.
Next, we're going to have a new trial concept. Before we get into the active and pending trials, we got together with the Radiation Therapy Committee and had a ex parte discussion at the SWOG retreat this summer about the possibility of doing a TMI, so total marrow irradiation clinical trial. And I've invited Dr. Jeffrey Wong, who's chair of radiation oncology at the City of Hope, to update us on their leading experience in this area and possibility of doing several clinical trials, initially potentially through SWOG and the NCTN, and then ultimately as part of the MyeloMatch transplant schema. Dr. Wong, are you there?
Yes, I'm here. Can you hear me?
Yes, we can. Great.
Okay, great. Thanks so much for the invitation. I'll be presenting along with Dr. Stein, Dr. Almalki, and Dr. Nakamura I'll provide a brief overview of our total marrow irradiation experience, and our hematologist will provide discussion regarding the trial concepts. This would not be possible without extensive collaboration between our two departments, radiation oncology and hematology, as well as a host of other people. Dr. Stein and Dr. Almalki, who you see up there on the upper right, are leading the trials that I'll discuss. Total marrow irradiation is really, we wanted to address the challenges of TBI, the side effects related to that, the fact that you cannot deliver TBI to older patients, the inability to add TBI to a reduced intensity regimen, and the inability to dose escalate. So we needed a more targeted form of total body irradiation, and we have used the term total marrow irradiation or total marrow and lymphoid irradiation. Next. A lot of our effort was focused on these types of data that were had just come out at the time we were developing the concept. This is a randomized phase 2 trial that I'm sure you folks are familiar with, AML CR1, randomized, this is a Fred Hutchinson trial, 12 gray versus 15.75 gray. And what it showed was the relapse rates were lower with the higher dose of radiation, but any gain in survival was offset by an increase in non-relapse mortality, primarily due to hepatic and renal toxicity. There was also increase in acute GVHD and mucositis. Next slide. The development of TMI was, we started the concept development in 2001. The main point of this slide is that prior to treatment, we took a CT data set from a patient with AML, and we did planning comparing TBI 12 gray to TMI 12 gray to TMI 20 gray. And we could, if you can see that bar histogram on the lower left, that we could keep the organ doses below that of standard TBI 12 gray. With the exception of lung, it began to become comparable at TMI 20 gray to TBI 12 gray. So all our trials from the start capped the highest total TMI or TMLI dose at 20 gray. Next slide. There's some animation on the slide, but this looks like the PDF. All right, so let me just kind of walk you through this slide. On the organs, these are the ones that we contour to reduce doses to these organs. We've had over the trials have developed several forms of targeted TMI. The bone and bone marrow were the original target areas. This was in a tandem auto transplant trial in multiple myeloma. But most of our effort has now concentrated on acute leukemia. We added as target regions the lymph node and spleen, this is in an older population, and we use the term TMLI. In the younger population, we have escalated to 20 gray, keeping the liver and brain to 12 gray and sparing the other organs. And if you look at this dose distribution pattern on the right, you can also call this an organ sparing or multi-organ sparing form of TBI with boost to marrow, lymph nodes, and spleen. Again, this is for the allo setting and the younger patient population. From the start, we have not targeted full dose to the mandible or maxilla in an effort to keep the oral cavity dose as low as possible and keep mucositis levels at a low level. We've kept the same fractionation schemes as standard TBI from the beginning because there were so many variables that were changing. We've delivered at 1.5 to 2 gray twice a day. The average dose rate for these technologies to the target site is 70 to 160 centigrade per minute. And for reasons I just mentioned, we've capped dose escalation at 20 gray for our trials. Next slide. This is a detail of how the patient is planned and treated. I'll be presenting at the Radiation Oncology Committee later today. So let me just point out a few major points in general. First, you can treat these patients on various technology platforms. The initial effort was with a platform called tomotherapy made by a company called Accuray Incorporated. But now you can treat on a Varian unit or an Electa unit. I don't know if you folks are familiar with the different technology manufacturers. It's termed VMAT. And the plans are comparable. The doses to targets are comparable. The organ sparing are comparable. Even the plan time and treatment time is shown here are comparable. We also use auto contouring software, which we can share, which really helps reduce the time it takes to plan these patients. Next slide. TMI and TMLI at City of Hope at the beginning was really not meant as a replacement for standard TBI. We wanted to address an unmet need and expand the use of radiation to perhaps a new population of patients. So our initial trials focused on patients with active disease who had poor outcomes and no standard HCT options. And as mentioned earlier, older patients who could not tolerate standard TBI, we wanted to see if we can offer them a radiation conditioning regimen. We wanted to reduce toxicities, as mentioned, dose escalate safely without increasing toxicities. We treated the first patient in June of 2005. Over 500 patients with acute leukemia have been treated, almost all on trials. We concentrated on a certain subset of patients with acute leukemia, and I'll go through briefly these categories. In the younger patient population, this effort is led by Dr. Stein. The initial trials were in relapse refractory disease. And then Dr. Al-Malki looked at a haploidentical HCT regimen, combining TMLI and post-transplant Psi. And the most recent trial, which is one of the basis for the proposed concept, is moving TMLI to a AML in complete remission population, perhaps as an alternative to TBI, again, combined with PTCY. Dr. Rosenthal, who has since retired, and now Dr. Al-Malki is leading the effort in older population, adding TMLI to an established flu-mel reduced intensity regimen. Next slide. This summarizes the, you could go back. You can go forward one slide. This is a younger patient population, again, with active disease heading into transplant. These studies were presented at ASTRO and EBMT in 2020. This is the phase 2 study, which is coming to an end, again, led by Dr. Stein, who's the PI. The phase 1 trial was initially completed, showed that we could escalate safely to 20 gray. This phase 2 trial, again, younger patients with active disease, mostly AML, and treated with TMLI. And you see the color wash on the lower right. The TMLI is delivered twice a day in 5 days, followed by etoposide and cyclophosphamide. Next slide. This summarizes patient characteristics and gives you some dosimetry data. The table on the right, main points are mostly AML, as mentioned, mostly induction failure. Almost all the patients had detectable blasts within the marrow, and about half of the patients had detectable circulating blasts. So a lot of tumor burden heading into transplant. The mean organ doses were 20 to 51% of the prescribed dose, which was 20 gray to the bone and lymph node and spleen. You can see the mean organ doses lower down on the table on the left. The lung dose is 9.1 gray, kidney dose 7 gray, oral cavity very low at 4 gray. And more recent efforts have continued to decrease the gut dose to about 5 to 6 gray now. And the lung dose we try to keep below 8 gray. Next slide. This phase 2 study with about 2 years of follow-up, all have engrafted, a CR rate of 100% at day 30, bone marrow, to 2-year progression-free survival rate, encouraging at 33%, the estimated 2-year overall survival, 48%, the NRM or non-relapse mortality rate, 9% at 2 years. No major differences we could see between the AML and ALL subsets. Next slide. The next trial is combining TMLI with PTCY. Next slide. This trial was recently completed and published. Basically, it took the Hopkins regimen of PTCY and added, instead of 2-gray TBI, it added TMLI, dose escalated up to 20 gray. Next slide. We were able on this trial to get up to 20 gray. You can see the color wash on the right. It's identical in terms of what were the target organs as the previous trial. Again, a younger population. This time, not all active disease, also patients with CR1 and CR2, median age 37. Next slide. With a median follow-up of 2 years or almost 2 years, we reached a recommended phase 2 dose of 20 gray. There was 1 grade 3 toxicity at 18 gray, but we were able to dose escalate up to 20 gray. The NRM is low at 2 years at 13%. The overall survival and progression-free survival are encouraging. The GVHD risks, both acute and chronic, are also low, and we felt we were able to dose escalate without increasing GVHD or non-relapse mortality rates. There's a phase 2 trial that's ongoing led by Dr. Al-Malki. Next slide. And then this slide again takes the strategy of TMLI plus PTCY into a standard transplant population that can get usually TBI. And these are patients with AML in complete remission. This has been recently published, at least the first 18 patients. Again, this is a pilot trial of 20 gray and PTCY. You see the regimen here. There's no chemotherapy before the stem cell infusion. And the PTCY, you see at days +3 and +4. Again, the same color wash as in the previous trials for younger patients. Next slide. Again, this trial essentially combines TMLI 20 gray with PTCY in AML and CR1, CR2 with matched donor. The composite endpoint was our primary endpoint, which is GRIFs, and you see the definition of GRIFs below. Next slide. Can you back up? 18 patients. No, go for it. 18 patients were in the initial published report. Median age of 40. You can see the characteristics there, 17 of 18 with intermediate to high risk cytogenetics. We saw appropriate time to engraftment, and it was well tolerated. There were no grade 3, 4 toxicities or deaths, so the NRM rate was 0%. Next slide. Again, with a follow-up close to 24 months, the GVHD risks are low at 12% or so. To 2-year estimated overall survival and leukemia-free survival were in the 83 to 86% range. The NRM rate at 2 years is mentioned 0%, and the GRIFs rate at 2 years is close to 60%. This compares favorably to, this might be on the next slide. Could you go for it? Yeah, this compares favorably, this GRIFs rate compares favorably to our historical results, also recently published with TBI 13.2 gray with Cy or Toposide. And we showed a GRIFs rate of 39% at 2 years. All patients, or almost all patients, discontinued immunosuppressive therapy after about 1.5 years. And again, low toxicity and NRM rates. There's a larger phase 2 trial that's underway. We're up to about 30 patients, and the results are similar. Next slide. And finally, this is the older patient population. This regimen is also part of the basis for one of the other proposed concept trials. Next. Again, this is to try to add TMLI onto a backbone of an RAC regimen of fludarabine and melphalan. The original trial was not dose escalated, just 12 gray to the bone marrow, lymph nodes, and spleen. The liver, in this case, and the brain were not target organs. The schedule you see here, 1.5 gray twice a day for 4 days, fludarabine given on the days of TMLI, followed by melphalan. Next slide. We had a recent update of this population reported in 2018, 61 patients, again, older patient population. In this particular report up to age 70, we've used this regimen in patients even older than age 70. Again, mostly AML in this mixed population. And you can see people had comorbidities with 7 prior transplant in 7 patients. And also patients at high risk, induction failure, and the rest you can see in the table there. Next slide. These are the results. This graph on the left, with long follow-up, median follow-up of 7.4 years, you have a 5-year estimated overall survival rate of 42% and event-free survival of 41%. You can see that the curves appear to plateau. We feel this is very encouraging, appears to be better than historical published data. The non-relapse mortality rate, you can see on the right, this seems to be similar to fludarabine melphalan alone. Next slide. And currently, we are taking this approach in a phase 1 dose escalation trial. We're trying to escalate the TMLI dose. We found that it was challenging to escalate the TMLI dose if the fludarabine was given on the same days as radiation therapy. So the current phase 1 trial, which is ongoing but nearing completion, again led by Dr. Al-Malki, gives the fludarabine after the TMLI, slightly reduced from the last trial, also a slightly reduced dose in the melphalan. We have 2 arms to this phase 1 trial, one with matched donor, one with a haplo donor, and with the haplo group, they have PTCY. Next slide. I did want to mention a few other things. We published on the TMLI toxicities, and they appear to be lower than that of what's been reported for standard TBI. We've seen no evidence of increased relapse rates in the areas that are not targeted or the areas where there are lower radiation dose. So I wanted to mention that. And we've had no problems or difficulties with engraftment with this approach, even up to 20 gray. So thank you. And I'm going to now turn it over to Dr. Stein, Dr. Al-Malki, and Dr. Nakamura. Anthony?
Yeah. Thank you for inviting us to share our work using TMLI. Based on the studies performed at City of Hope, we have basically two proposals to make to SWOG. The first proposal would be for patients over the age of 60 with MRD positive disease or with up to 10 to 20% marrow involvement, because this group of patients usually are not transplanted. The patients would have up to maximum of 2 induction cycles. The donor could be matched, mismatched, or haplo. The regimen would be TMLI, and it would be 12 gray, and this would be given in over 4 days. The fludarabine would be given after the radiation to reduce toxicity as outlined by Dr. Wang. This would be given for 3 days, and the melphalan dose is lowered to 70 milligrams per meter squared, again to reduce toxicity. Patients then receive PSCs or bone marrow on day 0, and patients get standard PTCY, tacro-MMF for GBA prevention. This would be randomized to the best non-TMLI HCT care for a patient over the age of 60 with MRD positive or up to 10 to 20% blast in the marrow. The endpoints would be, proposed endpoints would be 1 year overall survival, 1 year disease-free survival, 1 year non-relapse mortality, and we will also have a quality of life questionnaire to assess quality of life of patients undergoing the two regimens. All right, we can move to the next slide. Can we move to the next slide?
Looks like you're on that slide. Oh, there you go.
No, this is still the previous slide.
The CR1 AML.
The CR1, CR2.
Yeah.
Okay, so this second proposal would be, again, a randomized trial for patients with AML in CR1, CR2. It would be for patients under the age of 65. The donor would be, this would only use matched donors. Patients would be randomized from between our TMLI trial, which gives 5 days of TMLI, 2 fractions a day, and they get 20 gray. After the last dose of radiation, they get their bone marrow PBSCs infused, and then all patients receive cyclophosphamide on day 3 and 4, followed by tacrolimus, and this is given until day 90, and then tapered off. This would be randomized again against the standard of care investigator choice, and the possible myeloablative regimens could be FTBI-Cy for those people who don't use radiation. For patients with AML, the other regimens could be Bu-Cy, Flu-Bu, or Flu-Mel. Again, the endpoints would be 1 year overall survival, 1 year disease-free survival, 1 year non-relapse mortality, and again, a questionnaire for quality of life, and to see how many patients actually need to remain on immunosuppressive therapy after 1 year of treatment, after 1 year of post-transplant. So those were our 2 proposals, and I think we're open to any questions.
Okay, so I put down a few questions for you to start, and then we'll allow the audience to talk. I think based on your results are very impressive, and first of all, thank you again for presenting today. Having treated over 500 patients, you're very familiar with this, but a lot of us have not done this before, and I guess I would be a little bit nervous about letting this loose, if you will, on a bunch of centers that's never done this before. So the questions are, how feasible is it for the SWOG and NCTN to do this based on technical aspects alone? What are the equipment needs and costs per center that would be in addition to the equipment and the needs that are currently used for TBI?
So for the first, so at least for the first proposal, where patients are only going to get 12 gray of radiation therapy, this could be given on a regular radiation machine. Dr. Wang can back me up. This can be given on a regular radiation machine and would not require any additional equipment cost. Dr. Wang can comment.
Let me comment. There are 2 platforms, or 3 actually, Elekta, TomoTherapy, Varian. And basically, Varian is the largest install base in the US. In Europe and Asia, perhaps there's a little bit of more of a mix. all technology platforms can deliver this to any of the doses that we just mentioned. We have met with dozens of centers, and many have started programs, many outside the US, but the ones in the US, for example, are Dana-Farber has started, Andrew Ang has mentioned that, and then Butena at MD Anderson has started. And I don't know if there's anyone from MD Anderson or Dana-Farber online, but I think they can confirm that. Kansas has reached out to us to get started. Oklahoma, I see them on the list of centers. I don't see this at all as a technical challenge. I think everyone's capable of doing it. I think main challenges, if there are any, is to get everyone on the same page and wanting to do this. And again, collaboration between radiation oncology and hematology is we think, very critical.
So the second question is, whenever we try to send a patient over for radiation therapy, they're always swamped. And how much time would be required to set this up and perform for each individual patient for a busy center? And is this something that would prevent larger uptake?
Yes, that could be a challenge. If you are a center already doing TBI, I think you would have an easier time of transitioning. Instead of TBI, perhaps these patients would go on to a TMI type of regimen, especially the one with AML CR1, CR2. So we haven't seen that challenge at all if you're already doing TBI. And it kind of speaks to my earlier point. I mean, radiation oncologists really have to be on board also. I think starting out with just a few patients per one patient per month, perhaps at the beginning, and slowly building might be another strategy. But it does take additional time on a machine that sometimes already has a full schedule. But we'd be happy to meet with them and kind of walk them through the process, show them how straightforward this is, and see where it goes.
So would they have to, was there any specific training that they need to be? Are they certified to do this for insurance purposes?
Yeah, there's no formal specific training. What we've done is we've had on-site meetings or Zoom meetings, these on-site meetings take about 1 to 2 days. They bring the team on, they review the setup, they go through the planning process, they go through the contouring process. They then get started on their end. We've offered our time to review their plans and to refine their initial plans. I didn't spend too much time on that technical slide, but there are auto contouring software, AI software that we are sharing so that it could really cut down their contouring time. That's where they have to outline each organ in this full CT data set, cut it down to 2 to 3 hours, which used to be about 6 to 8 hours. There is also what's called a dose library, a planning dose library. We now have a library of about 120 patients, which makes planning much easier. They know what targets to try to plan to, so to speak. They know what dose ranges to try to meet. So I think that should all help. And again, we're willing to share that. In fact, some of it's published, so in the public domain. I hope that answers some of your questions or concerns.
Yep. Is this reimbursable by Medicare?
I can't speak for every center, and perhaps Dr. Nakamura can comment. At City of Hope, we've had no problems with this being reimbursed. It's a form of radiation therapy, and it's all part of our payment model. I'll leave it at that unless Dr. Nakamura wants to comment.
No, thank you. This is Rio. I hope you can hear me. That right, we have not institutionally had issues with the coverage at this point, but right, something I think we should be aware of and keep a close look if we can move forward in the network here.
Okay, and the last question that I have is for your AML and CR1, what's the event-free survival for MRD positive versus MRD negative patients?
So this trial, the trial that Dr. Wang presented is only for MRD negative patients. We have not expanded yet to for MRD positive patients, if they below the age of 60, then we use our more intensive regimen than the one that Dr. Wang presented.
Okay, anybody else have questions? Rich?
I think it should be mentioned, we're looking at the MRD positive subset in the younger population, and those results are.
It should be presented it should be, well, not about, it was submitted to ASH.
So isn't the relevant question here is whether this approach to radiation is better than TBI instead of the focus that you presented here?
Better than TBI or other preparative regimens?
Well, this is a variation on radiotherapeutic conditioning, and so wouldn't you want to know if it's any better than the standard TBI approach before you embarked on much else?
Well, that's why we were proposing the second proposal was for AML CR1-2, where you would use the TMLI regimen versus best. I mean, the problem now is that a lot of centers for AML in first or second remission don't use radiation therapy.
Yeah, so there's ample data out there that show that, for example, BuSci and TBI-Cy are equivalent. So we use them interchangeably.
So that's why it would allow non-TBI. I mean, if a center wanted to use FTBI, they could. If they wanted to use a non-TBI regimen, they could use a non-TBI regimen.
I think in terms of understanding toxicity and so on, you really need to make it TBI versus this. I mean, I think otherwise it's not going to be clear, whether are advantages to this.
Well, I think the hope for advantage is that there's better clearance of MRD positive disease or
have Actimab in the portfolio that might do that as well.
Correct.
I mean, if this does come to fruition, I would leave it to a working group where if you can if you can find a better comparable group to randomize patients between, that would be open. That would be open for discussion.
Well, I think the first trial would be, because this is a new technology and sounds like labor intensive up front, that the first trial would be to prove that this can be done in a multi-institutional setting, and whether that's a single-arm phase 2 or a phase 2 randomized trial in patients with active disease, to me sounds like the first trial that should go forward. And then subsequently, once that's decided on, then a randomized trial for patients with MRD positive or even MRD negative disease, in which the endpoint is progression-free and overall survival.
Yeah, I mean, I was in agreement with Rich that, it seems to me that a randomized phase 2 study comparing 2 different preparative regimens with radiation would be the best way to go, because I agree. We're also looking at toxicity differences. That seemed to be one of the standouts of this, is non-relapse mortality was much lower in their hands. And this way you can, if you're doing a smaller randomized phase 2 study, you might be able to do it, in the context of the BMT CTN, or at least centers that already have this technology and feel comfortable using it, instead of the very steep learning curve. I think we've all learned with any clinical trial, right? The first patient may not get the best experience at your center with chemotherapy or radiation or anything on a clinical trial. And then the second point is I still think, though, just given the biology of acute leukemia, I'm having trouble just wrapping my head around why radiation therapy to a smaller area of the body and a disease that is systemic and circulating might have a lower relapse rate, a better relapse-free survival. Their data looks really very promising, but until you do a head-to-head comparison of two different radiation therapies, I don't think you can answer that question either.
Well, again, the initial study he showed from I think it was Seattle, showing 1320 versus 1575, et cetera, did show better disease control with higher doses of radiation therapy. But I'll give you the point that this is not total body radiation. So I personally don't have a problem in saying radiation versus radiation, but does anybody else have any thoughts or comments?
Hi, just Ryo Nakamura again. Just kind of expanding on the discussion about kind of systemic disease as a nature of leukemia. Still, I think there is a component of locality, or this could be more local disease than we think, and that the microenvironment and kind of correlative studies that are ongoing in the program City of Hope with Susanta Huey, and more additional imaging studies that are funded by the NIH that are accompanying with our programs. That I think it's still some biologic interest in these modalities, along with the local toxicities in the non-marrow tissues and organs, especially GI tract, in relation to subsequent GVHD and so forth.
Okay, so next steps, we'll circle back to the folks at City of Hope and see if we can come up with a proposal to bring back to the Leukemia Committee. And again, I think that this is not ready, certainly for MyeloMatch by a long shot down the line. And I guess I'd like to use this potentially as a way to broaden out these number of centers that are capable of doing it, and having a pilot study in SWOG or NCTN to allow new centers to adapt this therapy and then begin to test it might be the best first new step for me.
So if I can just add one forward question, the place where we, I think a lot of us like to use TBI as part of the preparative regimen is in ALL. And I know there are a lot of challenges and where transplant is going to fit in B cell or, ALL, but definitely still has a big role in T cell ALL. So my question is, does the City of Hope group have any data regarding using especially TMLI in ALL, and would that be an area to explore two different regimens of radiation therapy with high-dose Cytoxan and look at toxicity and relapse rates?
So the only group where we've used TMLI for ALL patients have been for patients with relapse with active disease. And we have not seen any difference between AML patients or ALL patients. But also for ALL patients, there's literature out there that shows that having etoposide in your conditioning regimen plays a role, or if you use a flu TBI regimen, that seems to level the outcome between a non-etoposide regimen versus an etoposide regimen. So for ALL, we haven't quite, for ALL with the numbers only being very small for a single center to make any meaningful results would take a large number of patients. But that would be an ideal setting where everybody gives radiation therapy, and it would be a good comparator.
Okay, so we'll come back. We'll continue to have the discussions offline. And again, I'd like to thank Dr. Wong and colleagues for presenting today. So let's move on. Next, SWOG 2114, we're going to do some protocol updates. This is the consolidation trial after CAR T therapy. Brian?
All right, thank you. Good morning. Brian Hess at MUSC. We opened this trial up and launched it last April at the spring meeting. And this is the phase 2 trial of consolidation therapy post CD19 CAR T for large cell lymphoma. And just to remind everybody, we developed this study for large cell lymphoma patients that are high risk for relapse post CD19 CAR T, which we're defining as having a stable disease or partial remission at that 1-month PET scan. So in this study, patients can consent and register for the trial anytime after they consent for CAR T pheresis or CAR T collection, anytime up until lymphodepleting chemotherapy starts. All patients registered to step 1 will have a 1-month PET scan that will be centrally reviewed, which is taken about 5 to 6 days. I'll have another slide on that briefly. Patients that get into a complete remission on that 1-month PET, followed for PFS, OS, and translational studies. Patients with progressive disease come off of study. And then again, these patients with stable disease or partial remission are eligible for randomization to one of these 3 arms, one of these 3 consolidation arms, or observation. If you're randomized to observation, you can cross over to the Mosin and Pola combination if you relapse within 1 year of randomization. So the primary objective of the study is PFS. We're looking to improve the 1-year PFS of each of these consolidation arms versus observation. Translational endpoints are focused in minimal residual disease, not only for these PR or stable disease patients, but for all patients registered to step 1. We've estimated that we'll need about 400 patients registered to step 1 to randomize 120 patients to step 2. So like I said, we just launched this study a few months ago. About a week ago, we had 16 patients registered. As of this morning, that's 19 patients. 2 patients have been randomized to step 2. We've had 6 PET scans that have been centrally read. So just to reiterate some of the logistics with each step, and just in step 1, the window for that 1-month PET, or I'm sorry, step 1, the window for registration is from consent for CAR T pheresis until the start of lymphodepleting chemotherapy. Patients can receive bridging therapy, but you cannot receive Pola or Mosin. This is most likely to come up with patients, potentially receiving Rituxan and Pola or something like that. They would be excluded from the study. Any patient needing bridging outside of steroids will need a PET scan after bridging, showing that they have measurable disease. That's clear in the protocol. And so some common exclusions that we see is, again, patients receiving Pola as bridging, having a CR after bridging therapy, or having symptomatic CNS disease. I say these are common exclusions, but these come up very infrequently. I would say that at our center, 4 out of every 5 patients getting standard of care CAR T qualify for this study and are going on study. So for step 2, that 1-month PET needs to be completed within 25 to 40 days after CAR T. In terms of the central review process, these PET scans are uploaded by the local site team, centrally read by IROC. The result goes to both the study chairs and the sites. If there's discrepancy between the central read and the site read, or if the local PI disagrees with the central read, adjudication is possible. We're currently formalizing that process. The report is then uploaded to SWOG, and then the site randomizes the patient if they meet the eligibility criteria. So they're not randomized right when they are found to have stable disease PR on that central read, you still have to have a neutrophil count greater than 1,000, platelet count greater than 75,000, et cetera. So from the day of upload from randomization, it takes about 5 to 6 business days. So you get a PET scan, that 1 month PET scan on Wednesday, expect to have that result by the next Wednesday or Thursday. At our site, we're getting that PET on, for instance, today, we're scheduling that patient for a potential consolidation infusion 2 weeks from that PET scan, assuming they may have stable disease or partial remission, and we can always cancel that infusion. So again, based on those 1 month PET results, these CR patients undergo observation, but they still follow the imaging and biomarker draw schedule. The imaging schedule is based on standard of care, so there's really no extra visits for these patients. Partial remission stable disease patients need to be randomized by day 60 and obviously need to meet that eligibility criterion. We want them to be treated within 2 weeks of randomization, and then these progressive disease patients are off trial. And so in terms of the schedule of response assessments and blood draws, patients have these prior to lymphodepleting chemotherapy at that 1 month PET, and then it's based on whether or not you're randomized after that day 30 PET. So currently at our site, again, the accrual has been running very smoothly. We're still waiting on a number of sites to open this up. A lot of sites are in the activation phase. Over the last few weeks, we've had a number of sites open it up. So I really expect the accrual to have a significant uptick in the next 6 months, and hopefully we'll be presenting that at the spring meeting. But if anybody is activating the study or already has the study activated, feel free to reach out to myself and the other study chairs if you have any questions. And happy to take any questions now.
So you had 3 PRs and 1 stable disease, but only 2 people are randomized. Is there a problem, or is it just a timing issue?
Yeah, so the one patient had a PR and there was adjudication that occurred, and then the patient subsequently decided that he didn't want to move forward with randomization. The other patient, the 2 patients that were randomized to consolidation are on my site, or at my site. They were randomized to Mosin-Pola and Mosin, and each of those patients has a PET scan coming up in a couple weeks. The other patient had stable disease at my site and had LFT abnormalities that disqualified him. And that was the first time I've really ever seen that with CAR T this late. He had a liver biopsy, no lymphoma involvement. So I don't think that it's going to be 50% of patients that with a stable disease or PR are going to be able to randomize. We did, when we come up with these numbers of 400 patients to randomize 120, we did work in some drop off, but I think with higher numbers, that's going to get better.
Any other questions?
We put in a 10% drop off.
I have a quick question, Sari. I'm not a lymphoma guy anymore, and I'm definitely not a cellular therapy guy, but I do spend some time in the inpatient service taking care of these patients. And, the one late toxicity that I think we're seeing quite a bit of is the neutropenia. Mm-hmm. And will that somehow skew your population? Because you have to recover your neutrophils by day 60, and I've seen some that are much later than that. And are we selecting for patients that, may benefit from this?
We have seen some of that too. I think a lot of that, in my experience, has been based on how heavily pretreated they are and whether or not they got aggressive therapy as bridging prior to CAR T. I think that is not happening as frequently because CAR T is moving up into the second line, so these patients aren't as heavily pretreated. And so we still do see neutropenia, but I'm seeing most of those neutropenic episodes at day 30 resolving within a couple weeks. And this protocol also allows for a growth factor. You have to stop the growth factor within 72 hours of them qualifying for randomization, but it does allow for growth factor. And I did it actually on one of the patients that was subsequently randomized to consolidation therapy, and they're doing great. They're on growth factor for consolidation therapy, but they're doing great. So that's a really good question. Thanks for asking.
So that's allowed with those treatment arms, they can get growth factor.
It's actually, we encourage it. Yes, exactly.
So the question is, what are you recommending for bridging?
So, good question. We've been doing a little R-GemOx, a little single agent obinutuzumab based on what the tumor burden is. Infrequently, we've been doing some rice or something like that, but a lot of it depends on the tumor burden of those patients. Radiation I've been using a lot in patients with bulky disease at one spot, and that's helped a lot of patients, in my opinion, get to CAR T and have a lot of success with it. For those particular patients, if you have radiation, you have to, for all of these bridging patients, other than steroids, like I said, they have to get a PET scan afterwards to make sure that they're not in CR prior to lymphodepleting chemotherapy. But yes, absolutely.
Okay, thank you.
All right, thanks everyone.
Next, it's Brian Till is going to talk, give us an update on the ECOG mantle cell trial. I think he's online. Are you, Brian? Please say yes. Brian, are you there? We're next going to talk about the mantle cell. Okay, let's give it a shot here. And Jonathan's here and he can help. So this is the ECOG phase 3 consolidation trial with auto transplant followed by maintenance Rituxan versus maintenance Rituxan alone for patients who are MRD negative in first complete remission. As you can see here, there are 2 arms for those that are MRD negative by clonoSEQ, and for those that are MRD positive but have had responsive disease, they get auto transplant followed by Rituxan. And for those that are MRD negative but in a PR or MRD indeterminate, they also get transplant followed by Rituxan. This is confounded a little bit by the triangle study, which everybody knows that was presented at ASH last year in the plenary session by Dr. Dreiling, suggesting that there might be a benefit of ibrutinib therapy with chemotherapy. This has confounded things a little bit, but the bottom line is that they felt that the standard dose arm, standard therapy arm was doing a little bit worse than they would have expected. So there's still a question on the value of a transplant. And of course, everybody knows that rituximab after stem cell transplant is considered standard of care, improving the progression-free and overall survival. So did the preliminary results from the triangle change practice? It's unclear. The follow-up is short. We know that auto transplant and a mediated PFS following the Nordic regimen is about 8 to 10 years. The control arm of the triangle study was no better than the no maintenance arm of the Lima trial. Ibrutinib has been withdrawn from the market for mantle cell lymphoma. It's unclear whether second generation BTKIs will be covered as first line for this indication. And so the bottom line is that many centers are still offering first line auto transplant and still enrolling on the clinical trial. And we did an analysis of centers at the time of the presentation of the trial and the triangle trial, and everybody said that they would continue to go forward. So 605 patients have been assigned to treatment. About 80% were MRD negative. Target accrual was 689. Because the rate of MRD negativity was higher than expected, more patients went to arms A and B than C and D. So even though arm A and B targets have been met, the stats group allowed the study to remain open to get the total accrual to where it was supposed to be. And it's allowed us to keep the study open to see what accrual looks like in the post-triangle era. And that's it. Did anything I missed, Jonathan?
No, I think it's still very
Okay, next, Dr. Hagan is going to talk about the amyloidosis trial. Patrick?
All right. Thanks, Pat. Yeah, so switching gears a little bit here. Do I control this? Yes, okay. So thank you. We've presented this a couple times at this meeting now, and I'm glad to say we are almost over the finish line. So in light of time, I'll kind of go through the background here a little bit, but essentially this is a randomized trial looking at optimal consolidation in amyloidosis, looking at following the Andromeda-based approach, so Dara-CyBorD or Dara-VCD versus a consolidative autologous transplant. Again, due to sake of time, just really briefly, there's only been one study that looked at this. It's very outdated, 20 years ago, and it compared high-dose melphalan to oral melphalan with very high transplant-related mortalities. We know that in experienced center, and I would even say even unexperienced centers based on a lot of recent reports, TRM is very low in amyloidosis when patients are properly selected. It's a disease that historically had a lot of challenges in enrollment. And I think our experience here in SWOG and the Andromeda study has shown that that's probably not the case anymore. And practice patterns are really dramatically different. Here in the US, probably about a third of transplant eligible patients get actually transplanted. In Europe and other parts of the world, that number is much lower, probably in the 5% range. So, and it's a question we are continuing to face in our clinics with these patients with, really better induction therapy overall. And we do know ultimately that induction and actually dose of melphalan is really what dictates outcomes in these patients. So the primary objective of this study is to compare the modified PFS, or major organ deterioration progression-free survival, which is an important composite endpoint in amyloidosis that looks at not only hematological progression and overall survival, but also organ progression, which is critically important in this patient population. So this is a relatively newer composite endpoint, but we feel one that's very critical, that captures all the important aspects of clinical outcomes in these patients. Secondary endpoints we're looking at are really critically important as well, such as quality of life. So again, if the study doesn't show a difference, the quality of our patients and the symptoms they experience in these two approaches are going to be quite different. Obviously, we're looking at overall survival, we're looking at organ responses. We have some really, I think, nice translational science built into the study to look at minimal residual disease and then treatment-related mortality. So not just transplant, but treatment-related mortality, which is a challenge in this patient population. Here's the treatment schema. Again, I've shown this several times, but just by way of reminder, so if patients meet eligibility, which I'll get to on the next slide, they undergo 3 cycles of standard induction with Dara-CyBorD. After 3 cycles, there's a registration step 2 where they're randomized to essentially continue the additional 3 cycles per, again, standard Andromeda approach, or undergo standard high-dose melphalan and autologous stem cell transplant. After which all patients go on to 18 months of maintenance daratumumab. In terms of kind of important eligibility, these are pretty standard transplant eligibility mostly. We do have an age cutoff of less than 70 because if you actually look at the data, very few of those patients are transplanted regardless. And it's included in many of the transplant eligibility criteria. Obviously, they have to have disease proven. They do have to have measurable disease. And in particular, a difference in their free light chains of greater than 2 because we don't have validated response criteria for lower disease levels. They have to have kind of reasonable performance. They cannot have severe cardiac disease, which is defined by our standard cardiac biomarkers. And just of note, even though the NT-proBNP and troponin T are here, we have built into the protocol troponin I and BNPs because those markers are variably checked at different centers, and they're all validated. So non-severe cardiac disease, some standard organ criteria. I think importantly, a creatinine clearance greater than 30, because there is, I think, a significant amount of data that when we transplant patients with worse creatinine clearance, many of them go on to dialysis, unfortunately. And then they can have up to 1 full cycle of any plasma cell-directed therapy and still be eligible, which is also really important because many of these patients are frequently initiated on therapy in the community before they're referred to us to consider for transplant. So that's a really important eligibility criteria. After they undergo their initial induction, when they're set to be randomized at registration step 2, essentially all these are the same, except they have to have at least a partial response to induction because we wouldn't want those patients continuing the same therapy if they were randomized to not get a transplant. And then if they're randomized to the transplant arm, they have to be able to collect enough stem cells to safely proceed with transplant. So again, the primary outcome here is the modified progression-free survival based on kind of the published data from the Andromeda. It's estimated that it'll be about 31 months in the non-transplant arm. The transplant arm is the experimental arm. This is a 2-arm trial that's looking at 143 patients total that'll be actually randomized. We're looking to accrue around 30 patients per year over 5 years with 3 years follow-up. And we're looking to get an increase in the mod PFS of about 18 months, so 31 months up to 50 months in the transplant arm. So overall, that'll be, this analysis will be done once we have 192 events, but importantly, no later than 4 years after the last patient is accrued. So we're anticipating about a 15% dropout. That's kind of where our statistical modeling is based on, and this is due to about 5% of patients probably will have a less than a PR. And then we know there's toxicity in these patients. We're going to get some dropout before they reach step 2. So that I think is an important buffer built into our statistical plan. So that leaves us with about 159 patients per arm to get to the 143 that would need to be eligible for randomization. And then finally, there's some important stratification, which is the Mayo European modification of the Mayo 2004 staging, which looks at cardiac involvement, having at least a PR versus a VGPR in terms of induction, and then a T1114 translocation, because we know there's some data that dictates a better response to those patients who get a transplant. Finally, like I said, this is a really important part of the trial. There's, just like in myeloma, there's increasing evidence that depth of response matters in amyloid, no shocker there, and particularly a growing amount of evidence that patients were able to achieve MRD negativity by next-gen flow in the bone marrow. We're seeing improved organ responses, improved survival in those patients. So this will be done post-induction, post-consolidation, and then 1 year post-consolidation. Kind of in addition, we have a nice peripheral blood every 3 month biobanking we're going to do to look at mass spec-based assays in the blood. You know, we can call this MRD, you can kind of call it what you want, but there's also an increasing amount of evidence that that's actually a very important marker as well for disease control. And then I think importantly, we're going to be able to compare the 2 assays. So, you know, if we can actually correlate peripheral blood assays with MRD in the bone marrow, that might obviously offer a really important prognostic marker for patients who don't have to go a bone marrow assessment. So again, you know, potentially something that can be used, you know, off trial in the future, depending on the data that we see. So the primary translational endpoint on the trial is the bone marrow negativity post-consolidation, which is the randomization question. A bunch of additional secondary and exploratory endpoints are being built in, including comparing the 2 methodologies, and then the correlation between being MRD negative and actually being having a mod PFS based event. So I think we're going to have a lot of good, very interesting translational data here to work with, in addition to our standard SWOG biobanking specimens. And then finally, as I mentioned in the beginning, quality of life is really important in these patients. They have multi-organ involvement, a lot of morbidity. So we really want to be asking, as patients go through these 2 different methodologies, is quality of life throughout treatment and the long-term difference between the 2 approaches. So I think we have some nice QOLs built in. We're utilizing the PROMIS 29+2, which is kind of like an AL modification of the standard PROMIS tool. The primary objective there, again, will be post-consolidation, which is the randomization question. But obviously, we're building in additional secondary and exploratory endpoints with the additional data that we'll be collecting. So we're there. So I think that's the big news. I think we have some very minor hurdles. Kind of our activation, we're hoping will be this month. So, you know, this is a SWOG-led trial, but this has really been an intergroup effort. It's formally endorsed by the BMT-CTN. We have champions from ECOG and the Alliance. There's a lot of motivation, I think, to do this study still, despite some of the positive developments with induction and amyloid. So I think now it's time to get the study activated, open up some sites, and kind of get things going. So it'll be a little bit of a rah-rah time during ASH and Tandem, so the timing here is good. So we're excited. The meeting, you know, we're ready to get the study up and going. So with that, if anybody, I know we're kind of tight on time, but if anybody has any questions, I'd be more than happy to answer them in the virtual or the non-virtual world.
Nothing here. Nothing here, thank you. So we're looking forward to getting this open.
Me too. All of us are. Thank you, everybody.
Next is just a couple slides to let you know that the MyeloMatch Tier 3 venetoclax trial is still on the docket. Here's the schema. I just want to show this again briefly. It's not disappeared. And it's going to compare venetoclax with Flu-Bu or Flu-Mel, both for matched sibling donors, matched unrelated donors, and then a second group that's mismatched MUDs and haplo transplants. So we're in the process, hopefully, of getting this submitted to the MyeloMatch Steering Committee shortly, and then on to the steering committee. So we hope to get this activated pretty quickly as to the other MyeloMatch Tier 1 studies. Next, Dr. Hoffman's online. I saw him there. He's going to talk to us about the update on the CR1 transplant, auto transplant for PTCL. Mark?
Yep. Thanks a lot, guys. Can everybody hear me?
We can.
Wonderful. So you can go to the next slide, Pat. So I think as everyone in here is well aware, transplantation in CR1 is the current standard of care, but it's based upon some prospective data from the Nordic study and on retrospective data series. There has not been a prospective randomized clinical trial indicating benefit. And so the hypothesis here is that we would improve the 2-year PFS by 15% and the 2-year OS by 10% by transplanting these patients in first complete remission. Next slide. So this is happening in the backdrop of the French group has done a study with a slightly different design, but which is looking at a question of a primary PFS benefit. Due to the nature of their system, they are able to randomize at the time of diagnosis. And so patients are randomized to undergo standard of care induction therapy, and then half of them get transplanted and half of them do not. They are enrolling a little over 200 patients. The trial has started now. And again, this is looking at a PFS as the primary endpoint. Next slide. So this is the proposal that we had. For a variety of reasons, it was felt that attempting to enroll and register at diagnosis was not practical, especially given the referral patterns to the vast majority of our transplant centers. And so the registration enrollment would occur at the time of end of treatment PET-CT. Only patients who achieve a complete remission would be eligible. If on your end of treatment PET you do not have a complete remission, then you would not be eligible for the study. Those who are in CR would be randomized to either observation or high-dose chemo and autologous stem cell transplant, which would be done per protocol. There has been some argument, which is why this is in red, over the two endpoints. And I will share with you on the next slide some of the inclusion criteria, which I think have been previously presented. You can go ahead and go to the next slide, Pat. So this is the key inclusion criteria, and then the statistical analysis will be on the next side. We included a variety of histologies, as you could see. These are the main statistical diagnosis, and this is where the study has been hung up at least a little bit. And so it has been felt by many members that pursuing a PFS benefit is not nearly as useful of a statistical endpoint. We have been transplanting these patients for years, if not decades, and it has been felt that if we did not believe that this would result in a PFS improvement, that we probably would not be doing a transplant. The other piece is that when you're randomizing to therapy versus no therapy, it appears to be likely that in the patients with whom you're giving active treatment that we know to be effective, that the PFS would likely be prolonged. And so the real question here is, are you benefiting these patients on a long-term survival benefit? And so there have been a lot of folks that have been more interested in looking at an OS benefit. The other piece in that is that the PFS question, at least to some extent, should be answered by the French study that is currently enrolling. So next slide. So this is currently where we're at. So this has been deferred by the steering committee, and there are a few different pieces of the puzzle here as to why this was deferred. So number one was to justify our statistical assumptions better. That, I will be honest with you, is a little bit of a challenge. Most of the data we have are retrospective. I think we did a very good job when designing the study of coming up with the best available data in order to justify our statistical assumptions, and I think that by and large they're correct. And similar similar to what was done in the French study. Many felt that the trial would not be able to be completed due to the large sample size. And as I had mentioned previously, there's still some disagreement regarding the actual primary endpoint. And so I think that where we're at now is trying to figure out a way to reconcile these differences of opinion. And any thoughts that folks have here, I think would be most welcome. I know that we're running short on time. We only have about 5 more minutes. You should feel welcome to contact me via email if that's more practical.
Comments, thoughts? I guess the one that I have sent you is, of course, about 40% of these patients are CD30 positive, and randomizing somebody to no therapy is always a problem, and wondered that for that subgroup of patients, whether or not they could be put on brentuximab maintenance for a year like we did with the Hodgkin study. Because I think, again, getting 400 patients on a transplant versus no transplant trial is going to be difficult.
Yeah, I think that certainly has been part of the question. So I agree with you 100%. There has not been a specific conclusion on that question, Pat.
The French study reads out the PFS benefits, make it even harder to do the study.
Rich, you have any comments? Additional comments?
I personally liked the study, so, you know, I don't have a whole lot more to say without divulging confidential steering committee discussions. But in my opinion, OS is the appropriate endpoint here. And I don't know if you could add, you know, so brentuximab in that setting is not an established standard of care. So that
It is
would
for
be,
induction, yeah.
but not for as a maintenance. So that is a little bit problematic. The other concern for the steering committee, and this I think speaks to, you know, the committee's enthusiasm, and this went in the consensus review, so this is not confidential, is that given the heterogeneity of subtypes, that it might not be adequately informative of a specific patient. And so that was a big debate, and sort of comes into that whole category of, you know, perfect versus, you know, reasonably good. And so I think that's where things were stuck. And you know, I think this was withdrawn from PIO, and I guess the idea is if the investigators need to huddle and decide what they want to do. And you know, CTEP is happy to work with you guys on this. In my opinion, it's an important study.
Okay. So again, if anybody has anything specific to send along to Mark, here's the working group. So hopefully we can get this back on track.
You can. These slides don't need to be presented, Pat.
And last but not least, Dr. Ahmed is on, I think, online. She was here yesterday and then quickly flew back to Houston. Going to talk about the update on the Hodgkin's lymphoma trial in the last few minutes.
Thank you. I'm going to run through these slides in the interest of time. I'm not going to be done in a minute, but I will try to be quick.
You're fine.
Next slide, please. So basically, this is just to show kind of how quickly technology moves forward. If you can hit continue, please. And the E4211 protocol was a victim of how quickly we have moved forward in the paradigm of treating Hodgkin lymphoma. So initially, this trial was to look at remission induction chemotherapy plus or minus a checkpoint inhibitor in relapsed refractory classical Hodgkin lymphoma. And based on the data that we now have, I think that would be a problematic randomization for most people who treat Hodgkin lymphoma. So really, there's been a sit down to talk about what are other questions in this patient population that are important to answer. So in both the advanced stage classical Hodgkin lymphoma in adults and children, we have added novel agents to initial frontline therapy. And the recent data from the S186 trial has shown that nivolumab may actually come to the frontline sooner rather than later. In terms of remission induction, we know that Pembro GND is a widely used salvage chemotherapy regimen, and BV brentuximab and bendamustine is also used. Next slide, please. These patients are generally young and have significant long-term morbidity and mortality associated with the treatment that they receive for their initial lymphoma treatment. Next slide, please. So the question that we came up with that I think has been on a lot of people's mind is, does autologous consolidation transplant a requirement for every relapsed patient with classical Hodgkin lymphoma? And there is a growing body of literature that potentially there may be some patients who can be cured without high-dose therapy and autologous consolidation. But there's no established inclusion criteria or standard treatment approach for this group of patients. And in fact, a lot of the data is in a younger population. So I'm going to quickly go through the data for Checkmate 744, which was inclusive of the AYA and pediatric population. Now, this particular trial stratified patients at a very low kind of risk in terms of both stage as well as history of radiation and time between the diagnosis, treatment, and relapse. They did not have prior CPI or bendamustine or transplant in this patient population, but it did go all the way up to age 30. Patients were permitted to have prior BV, but it was a very small population of patients that actually had exposure to BV in this trial. And so the study design was 2 cycles of Nivo BV, and then they did have response assessment. They went on to another 2 cycles of Nivo BV, and the response assessment at that point determined whether patients would go on to a total of 6 cycles of Nivo BV if they attained a complete metabolic response, versus if they had a partial metabolic response, they would receive BV bendamustine for 2 cycles. And then subsequently, the entire population did receive ISRT. Now, patients who had progressive disease came off of trial. And in this patient population, the overall response rates were excellent, with, in fact, after 4 cycles of the induction, about 82% of patients, and again, induction was BV-Nivo, 82% of patients had a complete response with an overall response rate of 96%. And prior to ISRT, the entire population had a 92% CR rate. It was a fairly well-tolerated treatment without significant grade 3, grade 4 non-hematologic toxicity. Next slide, please. And the curves are really impressive. And this is, again, a patient population that did not have any autologous stem cell transplant, with a fairly good follow-up in terms of event-free survival and progression-free survival. Next slide. So our hypothesis is to identify a group of relapsed and refractory Hodgkin lymphoma patients who may not benefit from high-dose therapy and consolidative autologous transplant. And in terms of designating those cohorts, potentially patients who are rapid responders to immunotherapy could be one of the criteria. Based on the 744 data, slow responders may require additional treatment with or without chemotherapy. And then there is still probably a population of patients who need a consolidative autologous transplant. Now, the caveats are, how do we define early responders versus late responders? How do we define a low-risk population? And what is the role of radiation in this trial and in these patients overall? Next slide, please. So this is a very preliminary trial schematic. There's a lot of what ifs, but generally, looking at a patient population of relapsed refractory classical Hodgkin lymphoma, knowing that most of them will have had exposure to checkpoint inhibition and likely BV with their initial chemotherapy, and then potentially again with their salvage chemotherapy, would have response assessment. And based on that, if they attain a complete metabolic response or maybe a partial metabolic response, that's still unknown if that patient population will continue on this trial, would be randomized to nivolumab and BV maintenance or autologous transplant. And again, the role of radiation, whether that would be for the entire cohort or for a select number of patients, is still to be determined. And then if patients have a complete metabolic response at 4 cycles of the BV-Nivo maintenance, then they would go on to complete the 12 cycles. And if they do not attain a CMR at cycle 4, then the question is, would they have intensified therapy and continue on trial, or would that be a time point at which we should go forward and try to get them into a CMR and go to transplant? again, as I said, there's still a lot of what ifs, but would be happy to have questions and comments and really your thoughts about this.
Any comments here?
I'm surprised for a transplant group. When I first heard this trial, I was like, I'm not sure about this. I want to really define the low risk population because there's some patients who, as a transplanter, I'm not entirely comfortable on this trial. My pure lymphoma colleagues, I don't think have the same hesitation that I do. But I was hoping that you all would give me a little bit of insight on what you think from the transplant side.
Everyone's getting checkpoint with induction.
I'm sorry, I can't hear. Do you guys have microphones?
My question is if, with more people using checkpoint with induction, regardless of their salvage, if they're coming in a good remission and we're transplanting them, I guess that would be a patient I would probably still do maintenance post-auto transplant. I don't see a lot of these patients, but that would be my only question.
So I think the kind of sticking point to that is likely going to be the time between their initial treatment and their relapse. If we look at the Thera data and even some of the Pembro maintenance data, it's usually those patients who have a short interval between the time that they receive their frontline therapy and then relapse that we generally designate that we would do maintenance. But I think that's a very good point in terms of the higher risk patients who receive autologous transplant. The standard is to do maintenance, and we're foregoing that because of the trial. Is that potentially going to lead to worse outcomes in the transplant group?
Rich?
So the basic idea here is one that is comparing two strategies. One strategy is standard salvage and transplant compared to a strategy of deciding whether a patient can just continue with immunotherapy or do they need immunotherapy plus a transplant as a strategy. And the key here is how do you identify those that you can omit the transplant in? And, if we had some nifty thing like, ctDNA or some really sensitive, accurate marker, you could potentially identify those who have very, very sensitive disease to immunotherapy and choose those as the ones that would not have a transplant, and the others would get the transplant. And then at the end of the day, if let's say you were able to save 30 or 40% of the patients from a transplant, and the rest got a transplant, and then you're comparing the progression-free survival of that group as a whole to the group that gets a transplant, and if the outcome is pretty similar, and the idea is to use one of these hybrid designs where you expect it to be a little better in RMA, but it could be a little worse, but not much worse, then you'd still have a positive trial, particularly if at the end of the day you saved a certain proportion of patients from having to have a transplant. And so that's the idea here. And given the fact that this is becoming a rarer and rarer population, a design like that would allow a study of around 350, less than 400 patients, and would speak to feasibility. So, I think figuring out how to identify who are the really sensitive patients for whom you may be comfortable leaving off the transplant is sort of key here. How do you do that? Because we don't have a validated, circulating DNA test. That can be an integrated study here to develop it, but don't have that yet. So is it PET? What about PET after one cycle of investigator's choice, for example? Would that distinguish? Because otherwise, most of the patients kind of come out of their salvage as complete metabolic response, and then how do you decide who's going to not get the transplant in arm A? You're kind of in a dilemma there, right?
Yeah. So I think you've actually summarized all of the problems of the trial in about 30 seconds. And I think that we absolutely don't have a clean marker to designate which patients are going to be responders versus not. And ctDNA, we all know in Hodgkin lymphoma is right now not ready for prime time. My own bias is that it's probably going to have to be a combination of factors, including response assessment, as well as looking at their initial time of diagnosis, interval between frontline therapy and relapse, nodal versus extranodal, can it be radiated or not? Have they received prior novel therapy? And again, there's going to be populations of patients that we know potentially may not do as well. So for example, the pure primary refractory who do not respond to initial chemotherapy or chemoimmunotherapy, I think is not a population that you want to try no transplant on. And essentially, you've actually kind of summarized what we were talking about in terms of endpoints. I don't think you're going to have a similar, PFS of the whole group in terms of transplant versus immunotherapy alone. However, I think what we can do with this trial is look at which patient population didn't need the transplant. And while we know that a transplant is a procedure which is short-term decrease in quality of life, long-term benefit, it also leads to multiple, late complications, including infertility, including second primary malignancies. And so if we can eliminate it completely for a group of patients, we've actually done them a significant benefit. But it's the devil in the details of which population of patients is going to benefit.
I also think you need to contact the CIBMTR and see how many of these procedures are actually being done per year. And that should figure into your trial design. Because it used to be only about 1,100 procedures per year were done. And the CIBMTR says, you can expect about 25 to 30% of those patients being willing to go on trial. So you're really limited already to the number of patients because it's a rare disease. And now with 90%, 95% overall survival at 2 years and 86% progression-free survival with these new novel regimens, very few of these patients are really relapsing. In the old SWOG study, the average time to relapse after completion of therapy was 6 months, and these patients are doing much better than that. So I don't think these curves are going to drop significantly over time if history guides us. So I do think that's something that needs to be considered now. And as we talked about yesterday, the Memorial Group is already doing a no transplant trial pilot study, and by the time you get this up and going, they'll have those results, and that may impact whether or not a trial can be done in the first place. So not an easy trial. We should have just done the first trial.
Can I make a comment?
Yep.
This is Harry Erba. As a leukemia doctor, I'm incredibly impressed by the amount of thought and effort that you're putting into designing the study as the field shifts under you. And I'm saying that because going back to your first slide, if industry put as much thought into whether it was truly an advance for society to talk longer than 30 minutes on a phone and take shorter than 10 hours to recharge, I think if they thought about that, they would realize it really wasn't an advance for society. So you're trying to outdo the telephone industry, and kudos to you.
Okay, well, thank you all for attending, and sorry we ran over a few minutes.
Thank you.